So good evening, friends. At the outset, I'd like to invite everybody for this exciting day for the IAB EBUS certification course. So right now we are into the 7th module of the IAB EBUS certification course, and today the theme of the module is about EUS FNA and Transvascular EBUS redefining the boundaries. And so for you to get the certification, you need to attend at least 7 of the 10, at least all the modules, and you need to attend one hands-on workshop. So today we are going to have an exciting day with the talk by our very own Dr. Pattabhiraman. Followed by that, we have a panel discussion on the queries that we have in the subject of interest. Without wasting much of the time, I would like to introduce Dr. Pattabhiraman sir. We all know that Dr. Pattabhiraman sir doesn't require much of introduction, but it is my courtesy and duty to introduce sir. And he is working as a consultant interventional pulmonologist at Royal Care Hospital in Coimbatore, and he has been a visiting professor in the SRMC Chennai. He heads a full-fledged interventional pulmonology group along with the associates Dr. Arjun and Dr. Mahadevan under the banner called CAP, that is Center for Advanced Pulmonary Interventions at Royal Care Hospital in Coimbatore. And it is to our pride to say that Dr. Pattabhiraman sir has introduced the endobronchial ultrasound to the country in the year 2008 and the bronchial thermoplasty program in the year 2017. He has published 15 articles in IP and authored chapters in 2 textbooks, and has done extensive training for many of the doctors who are currently practicing IP throughout the country. And it is happy to say that I have been from the same city as Dr. Pattabhiraman sir, and it's always a pleasure to hear from him. And he's like one such mentor whom you can approach anytime. So over to you, Dr. Pattabhiraman sir, and he will be delivering the talk on USB, FNA, and Transvascular EBUS. How do I do it? Over to you, sir.
Thanks, dear Vishwesh. It's an absolute pleasure. Thanks again to IAB and Amita for this opportunity. I mean, I think people are getting a little tired. I've just come for the second time after the inaugural thing. And so let's just look at two things here. One is EUSB FNA and transvascular transvascular TBNA using an endobronchial ultrasound. Since we are on the topic of EBUS, and since we had lovely talks earlier, I mean, this is the 7th, and earlier we've described about how EBUS has to be used the way it was designed and designed to be used. And we had Dr. Ravindra Mehta, who gave a talk previously about mediastinal lymph node biopsies and the various techniques that he used. So I'm just going to go further and see can we take the discussion a little ahead. And for that, I've borrowed quite liberally Dr. Ravindra Mehta's slides as well. And so anyone who's seen Ravi's lecture would have identified the fonts and the background of this thing. And so much of it is shared between us, and much of the work also has been shared. So I mean, I'll have to give due credit to Ravi. There are other unique roles which can be explored, and traditionally, field of interventional pulmonology is replete with innovation, and that's how the science progresses. We've all, innovate because there are situations where you don't see in the textbook earlier, and you would not have seen in journals, and so you have to innovate. And EUSB, FNA, and transvascular are two such phenomenon that happened. So we're just looking at whether we can take EBUS application to what was initially not described for. So can we go levels higher? And more importantly, can we do this in our country safely and successfully? Safely being the operative word, because that's a very important thing in a country, especially when we lack a proper control. So I think this is an inherent thing that needs to be addressed. And it's an evolving story over the last 15 years. EBUS came in 2004. Especially the convex probe was 2004, and by 2010 it became a standard of care for the regular usage. And subsequently, using a combination of experience and literature and a liberal contribution from the Indian thing also, let's just look at how things have moved over the past few years now. So the lymph nodes accessible by convex probe EBUS, we've all seen it. Any lymph node which is around airway is quite game for an EBUS TBNA. So 2, 4, 7, 10, 11, 12. I wouldn't really be going to the detail because we've had wonderful accounts of these so far. And the lymph nodes not accessible were the following: the 5, 6, 8, and 9. 8 and 9 being paraesophageal, and 5 and 6 are beyond the between the airway and the vessels. The major vessels come between the airway and these 5 and 6 nodes. So you have a aorta or a pulmonary artery separating these lymph nodes. So let's look at the nodes in the esophagus. This was prepared for the this is a PET scan image for demonstrating the nodes around the carina. But what you can see is the 4L. This 4L node. This is a trachea, but you can see the esophagus, and you can see in a trachea you'll have to take a 90-degree, or it's a 9 o'clock position here. Whereas if the scope is the esophagus, you just have to look up, so it's almost straight up, and so it's the easier angle to pierce this lymph node from the esophagus rather than from the left side of the distal end of the trachea. So this is quite the reason why the majority of EUS people, people from gastroenterology, was because they had this tool earlier developed, and so they were kind of owning this space, especially with the station 7 and station 4L. The endoscopic ultrasound with a bronchoscope guided FNA came into vogue after we started slipping the tube into the esophagus, about which is this topic. This amounts to slipping this convex probe EBUS into the esophagus to sample lesions and lymph nodes around the esophagus. Disclaimer, the most important disclaimer, this being it's not necessary. You can do your EBUS life without this perfectly without any problem. It is tried only after one becomes very familiar with the procedure and complications, because remember, we are going into some foreign territory. Let's just look at the procedure in the following categories, and let's decide which procedure, EBUS versus USB FNA. Usually it's more complementary, which you'll come to realize once the talk is over. It's not that you'll have to do either EBUS or USB FNA. Only thing is, whenever you do a combination of procedure, first do a EBUS and then come to the esophagus, because the esophagus is not such a clean area as much as the bronchus is. So once you contaminate the needle via the esophagus, you don't really go to the other way and go back to the EBUS. So that is one important thing that you'll need to understand. It is easier to access the left paratracheal lymph node and paraesophageal lymph nodes. That's quite intuitive from the esophagus. Now, pre-procedure CT review gives a good idea, and it's definitely mandatory. And that will give you an idea about how accessible these nodes are from the esophagus. And subsequently, it depends on what happens on the table. So is it a big, transition from putting the scope into the trachea to putting the scope into the esophagus? Not quite, because, we have the Riles tube, which we've always done. The cardiologists also have the bigger scope with no endoscopic vision, which is the transesophageal echo. So how do you do this? And it's easy, because the Riles tube or the endoscopy less or endo vision less EUS, transesophageal ultrasound, which is a bulkier scope, can be done blindly. Here you also have a visibility. So you enter the esophagus by going through the oral route, position behind the arytenoid, preferably to one side. Ask the patient gently to swallow and slide the scope in. This is all that you'll need to do. It's almost like a Riles tube, but it's slightly bigger than that. So you'll need to identify anatomical landmarks, keeping in mind the fact that esophagus is an unfamiliar territory. Endovision is compromised. The scope wasn't designed to do this. EUS scope is, but not the EBUS scope. And the ultrasound landmarks definitely come to our rescue. So we had discussed this briefly in a Lung India paper, which we were the authors. We were just looking, it was a commentary about this after the first few papers came in, and so we did a commentary on this. And here in this article, we just discussed about the various aspects of how different USB FNA is when you compare with EBUS. So roughly around 2015, we also had a very clear paper, endoscopic ultrasound, which was showing the difference between EUS scope and EBUS scope into the esophagus. And you can see this. The EUS scope has a bigger scanning range, at least 120 degrees. You see a lot more things. So once you put in the esophagus, And you can see the diaphragm, you can see the liver, and liver is seen very clearly, and you can see the scanning range is wide. Whereas in the EBUS, the scanning range is around 60 degrees. Now it's becomes better, but this is in 2015. So you can see that this is one of the patients which had a pleural effusion with this a little bit of lung floating, and this is the diaphragm, and roughly this is the liver. So you can see that that is a small wedge of what you can see actually in the EUS. However, it serves a purpose. You can go a little bit up from that liver area, and then if you take the EUS, you can see the right pulmonary artery, left atrium, and the node in a very, very clear thing because of the nuances and the higher resolution of that ultrasound. But here we can still make do with it because we can do the whatever be the purpose can be served, because you can see the same thing, albeit a little on a narrower side, but we can actually place the node here and puncture it. So you can still have a similar looking vision where you have both the right pulmonary artery and you have left atrium and the nodes. You can see roughly around you can also see a 4L and a 7 at that particular area. 4L coming a little up than the 7, and as we already discussed, it's quite easy when you come back after you identify the right pulmonary artery and make a slight tilt, and you'll see it almost similar to what you see in a EBUS, where you have a Mickey Mouse, the famous Mickey Mouse, but it might not be a Mickey Mouse, but you can see two vessels with a lymph node and in an angle which is very easy to actually poke. So when do we actually think about it? It's usually patient related. Patient has a significant cough, a significant hypoxemia, where a general anesthesia is not very risk-free, and the patient is coughing a lot and has a lot of secretions. In those cases, since the cough receptors are a lot less in the esophagus, and you're not disturbing the tracheal thing, even in hypoxemic conditions, the patients can actually undergo this procedure fairly safely. And there can be lesion related. We've already discussed the nodes that are around the esophagus, like stage 8 or 9, poor accessibility from bronchus and paraesophageal lesion. Again, the most important thing which we has been multiply proved is to complete the evaluation of mediastinum in the setting of lung cancer staging, where after the EBUS, you can also do USB FNA to complete the staging. And we call this as a medical mediastinoscopy because we actually can sample node which cannot be accessed by even a mediastinoscopy. So this gives you a lot more robust evaluation of staging in the setting of a lung cancer staging. So Dr. Jukanima and the groups from Netherlands, they just looked at how easy is it for the pulmonologist to learn the EUS. Remember, this is not a EUSB FNA, this is EUS FNA. And they found that a pulmonologist with knowledge of lung cancer staging quickly improved their performance. However, they said 20 procedures were not enough to secure consistent and competent performance for all trainees. Some of them had put 17, some of them had 23. They looked at 4 people, but a USB FNA is a lot easier than US FNA. So this is again our group, which we were doing it in a single center. We published in ECBIP, the European Congress of Bronchoscopy Interventional Pulmonology in 2013, where we looked at the review of 67 patients that we had done over 4 years between January 2009 and December 2012. And we just looked at the specific pathologic diagnosis accuracy and the diagnostic yield, and found that it's an impressive 85 degrees and 85%. And I'll show we'll just discuss the paper a little bit subsequently. But after 2 years, then we had the PGA group, because we did not publish it, and they did a proper job. And they published with using 11 patients, and they found out that there is a significant sensitivity and specificity, and they think that it's a useful additional tool for diagnosing mediastinal lymphadenopathy. And they also didn't stop with the 11 patients. They did a wonderful systematic review of all the cases that were published so far. And you could see that bulk of them were done in supine, excepting a couple of groups which did it the left lateral. Most of them were pulmonary physician. Only one was a surgeon. And bulk of it was 4L and 7, and there were other 8 and 9 strewn across others. And most of it was in conscious sedation. And that is a huge difference between an EBUS TBNA and USB FNA, where a sedation requirement is a lot less. And what did the review say? The review said the additional diagnostic gain of EUSB FNA over EBUS TBNA was at least 7.6%, which is huge in the setting of already very high yield in EBUS TBNA. So even an additional 1 or 2% will be good. And here it's a whopping 7.6%. So which means that this is a very useful additional tool. So, and roughly same time, Dr. Oki and group in 2015, they looked at the comparison and they took a different thing and they looked at the safety, which was very important. They said that EBUS and USB FNA provided high accuracy with good tolerance, although occurrence of infectious complications should be monitored carefully. EUS FNA had a slightly higher infectious complication in what they in their group, and this is something that every one of us should be very conscientious about. In our own group, we had one of the patient who subsequently developed a rip-roaring sepsis with a mediastinitis who had to be managed in a different hospital with a lot of antibiotics. Of course, didn't require a surgical exploration, but this is a problem because you're passing a needle across through the mediastinum into the thing via esophagus, where there can be a chance of a contamination. So we'll have to be very mindful of that. Now, what if the patient is intubated? Again, the patient is an intubated patient. You can see this patient was referred from an ortho hospital where the patient was intubated after a road traffic accident and subsequently found out incidentally that they had a high FaO2 requirement, and they had a CT which showed a significant mass-like thing in the subcarinal region, compressing all over, and they sent to us for a diagnosis. Here, the patient's FiO2 requirement and PEEP requirement was very high. So using the esophagus, using the same bite block, but the endotracheal tube is there, and so it's easier to slip a tube when already the trachea is occupied, and we could actually do a simple USB FNA and found out that this patient had a squamous cell carcinoma. So again, this was published, and not this was published, another similar case was published, again from the PGI group, which said a case report and systematic review of literature, which showed a very good improvement in the yield whenever the patient has a high FaO2 requirement. And so this is a very useful conduit, esophagus being a good conduit when the trachea is already occupied. So EUSB FNA, the technical aspects are it's easier to shove a needle because you're not having a cartilage to contend with, so it just goes in easily. There is no cough or there is no hypoxemia issues. And you can see in such a, this is one of the patients that we did. You can see that this is the esophagus, this is the airway. On the look of it, this lesion, you will look at some other ways of making a diagnosis, including a radial probe and so on here. But if you look carefully, this is esophagus and this is a lesion, and you can actually puncture this. And this again was a malignancy. We could do this using EUSB FNA technique. Now, the boundaries are pushed further by Dr. Ravindra Mehta and group from Apollo Bangalore, and they did it in a 20-month-old toddler. This was actually the first case reported by Ravi's group, and they actually made a diagnosis. In fact, it was a very rare diagnosis. And subsequently, 7 of us together across the country put this paper up. Again, Sejal Duria was the lead author here, along with Karan Madan, and 7 centers participated, and we looked at EBUS, TBN, and EUSB FNA in children, and we found out that in about 12 subjects of them were by EUSB FNA because they were smaller of the age group, and this is the only way you could do EUSB FNA, and we could we could say that the sensitivity was 79%, and you could see that the change in diagnosis was up to 41%, which is quite huge, and complications were all minor. And it was in about 9%. So they said it was we found out that it was a safe technique with good diagnostic yield for mediastinal lymphadenopathy in children too. And so I just briefly, I said about the thing, and we'll elaborate on that initial experience. And we've stopped doing this as a routine because we are more and more, our center, we're doing a lot more of GA, and in which case we wouldn't have a regular basis, we would be doing this. And so EUSB FNA accounted for 15% of EBUS procedures then. And you could see that this was on that same time frame, there was about 376 patients in EBUS TBNA, 67 patients were done on EUSB FNA. The hypoxemia is the most common cause, and subsequently refractory cough, excessive secretions, and inaccessible lesions were the reasons. And these were the initial thing. There was no endoscopic vision, and the scanning range was already alluded to, but it is easy to pierce the wall. But we found out that to pierce the capsule, it was difficult. Now, in EBUS, the effort that you put to pierce the cartilage or the airway wall is enough for the needle. Once it comes out of that area, it just lands into the node because the node is very close to the airway. Here, we find a different problem. The needle can easily go across the wall of the esophagus, but the capsule is a little more thicker than the wall of the esophagus. So the capsule, along with the node, will keep pushing that around for some time before the needle actually engages. So you can see for some time it was just moving and suddenly it goes in, and after that you will feel actually the giveaway. So that is one peculiar technical issue here. And the airway and the node is together and you're going through the airway, and so there will not be an independent breathing that happens. Whereas in esophagus, the breathing is independent, so the trachea moves independent to the thing, and there is no needle to transfix the movement, so that the movement of the needle is independent of the tracheal movement. And here, once the needle goes in, you could see that the breathing will happen, and so the node will keep moving. So you don't need to do an actual FNAC because there will be a movement that is produced by the respiratory excursions, and the node will keep moving inside. The needle can be kept quite static as the patient breathes. The most important thing, however, is that the pathologist needs to know where the lesion has come from. So if you've just done a USB FNA and if you did not tell the pathologist, they see squamous lining, and that is not to be seen because it's quite different from the bronchial epithelium. So the squamous cells have no business being into a EBUS TBNA, and so they might call it as a squamous cell carcinoma. So unless you tell the pathologist, they'll be confused with the kind of cells that are seen. So to conclude about the USB FNA, it's an additional tool with no extra cost, requires minimal extra training and no major complications reported. This is the only scope that enters both the lumen and just a small video of that. After that, a few slides about the transvascular, and then we'll actually open up for the thing. So this is a small video where a USB FNA is happening, and you can see that the first thing is you go into the oral thing. You might have to lift the thing, and you see the vocal cords. Now you see the vocal cords, you go behind the arytenoid and ask the patient to swallow. So here they need the patient to be cooperative, and once you slide it across, it just goes in. The first thing you'll need to see is go and see the liver. So the first thing is you go as far in so that you can go to the liver and diaphragm. Once you see that liver and the diaphragm, then you can keep coming. So this is the diaphragm and this is the liver. This is the place that we go, and then you keep coming back and you'll see the left atrium, which is the posterior most, and then you'll start seeing the atrium, and so this is the right pulmonary artery, left atrium, and then you'll see the node. So as soon as you see this combination, you'll know that there will be a node here, which is the subcarinal node. So once you see the subcarinal node, you just lift it a little further, you'll see the left pulmonary artery aortic arch and the lymph node, which is the 4L. So you see both the 7 and the 4L. These are the two things that you will need to see and you will need to sample, because bulk of our work stops here, 4L and 7, and maybe a paraesophageal if you see it on the CT. Rest of it is done only by the EUS fellows. Again, we've had people from different areas, including, I think, Virotham and Karan Madan's group, who have identified the left adrenal if it is big. We haven't been able to do it even in a single case so far, and so I think those are things that can be done, but you'll need to get into a lot more of training here. And so just to look at the procedure, it's easy to push the the needle in. So it just goes in like it. Knife in the butter. So it's quite an easy procedure per se. And you don't need to do a lot of excursion. It keeps moving, but you'll have to ensure that you don't cross that, the boundaries of the node. You'll have to go capsule to capsule and do it. So it's a very, that way it's an easier procedure. There will be a technical difficulty in a smaller node. Because as we discussed earlier, the force required to pierce the esophageal wall is easy, but the force required to get into the node will be a little more higher, and so this is the 4L, and it's a very small node. You can see that the node is a little small, but you can still do it. So just showing that it's doable even if it is a sub-centimeter node. You can see that the needle has come in, and then you can do the steps of the EBUS is just about the same. So this is just to how I do it about the procedure, and let's get on to crossing the established line number 2, which is a transvascular EBUS. Again, some of the slides have been by Ravi. So let's just look at, 4 and 5 and 6, which are, which are not closer to the airway. And there is a vessel that is, separating between 5 and 6 node. Could be pulmonary artery and aorta, and both of them can be breached as been shown. Both the transpulmonary sampling and transaortic sampling have been done. But again, I would actually stick my neck out and say that these again are not necessary. We have to use and exhaust all the other possibilities of sampling these nodes. And unless all of them have been tried and negated, or have a solid reason why you're not doing it, like a huge bulla around there, or you have to pass through an emphysematics lesion, or if you've done that and not produced a result, only then you can go in. Some of the interesting case series, this is Ravi's case, where a 71-year-old lady who had a pulmonary junction malignancy, operated earlier, had a cough and shortness of breath with weight loss. And you can see that lymph nodes are here, but the lymph nodes are beyond the pulmonary artery. You can see that these are the areas where the lymph nodes actually are having a meet. And always have a setting of rows, and only if you have a conventional EBUS TBNA, you identify and find that its rows has been negative, you go into doing all these, and you can see that this is a pulmonary artery and this is a node, and you can see that the needle has gone through and through the pulmonary artery, and you could see an artifact where there will be a movement across like this. You can do a Doppler right through to know where you are, and most importantly is make sure that the needle is far in and your excursion don't go back into the vessel and come back in. I mean, that's not ideal at all. So you just look at the mass here, it's behind the pulmonary artery, and usually you will have it in a setting of a row so that you can identify it, and you'll have to ensure that you do as low number of passes as possible, preferably just one pass. And you could see that you could get a diagnosis from this is histopathology was a transitional cell carcinoma. So this was actually, this patient has had earlier a transitional cell carcinoma of the bladder, and this was actually a metastasis which was identified by only this, because previously station 4L, station 7, 11L, all of them bedside rows has been adequate and reactive lymphadenitis, and so they went inside this mass. And so this is done only in a setting of a negative rows with a accessible nodes, and all of them are negative, and only then they've done it and got it. And this is in our center, where there was a middle-aged smoker with a chest pain and node mass in the left upper lobe, multiple passes were negative, had a pneumothorax and necrosis on a CT guided biopsy earlier done in Kerala, and so it's referred here. You can see that this is the mass here, this is the airway, and this is the aorta with the arch, and and you have this is at the level of pulmonary artery origin, and this is ascending and descending. But here it's at the level of arch. You can see that the mass is here. Actually, there is a beautiful PET that shows that it's only in the margin that is positive. And you did this and you got a necrosis because the thin layer was, PET was not avid here. It was all necrosis, and we had to do it from this side. After discussing everything, and this was done, and this is way back 2012, actually. You can see that this is the aorta, and this is the whole thing is a mass, and you can see a dark center, which is a necrosis. This is a 3 centimeter aorta, and this is the space from there the needle comes in. And so we used all the 4 centimeters and passed across the aorta. And again, a problem, we had only a 60-degree scanning range. Now things are slightly better. But if you see the origin of the needle, you might not see the insertion because it goes beyond the scanning range. However, we know that it will be beyond 3 centimeter. And so we actually, use the Doppler, and then we push the needle, and we got a diagnosis of that patient was again a squamous cell carcinoma. Subsequently, we also had an intra-PA puncture in a patient who had a malignancy of, had a rhabdomyosarcoma, and he had a pulmonary embolism, which was a tumor embolism. So we pushed the needle and then got it in one case, and the other case was a pulmonary artery sarcoma, which we used a EBUS to do it. So this was intrapulmonary artery puncture. So we showed you both transvascular and intravascular, both across the pulmonary artery and aorta. Scanned paper for obvious reasons, started by Panchabhai, In 2015, this was the first paper to show about a single center, 10 cases of which they got a diagnosis in 9. Subsequently, Eric Folk also used a transpulmonary artery sampling in 10 cases. Very few cases did transaortic punctures, and there was in 2019 there was actually a multiple. They did a review, and they included Dr. Mehta's paper. Which is a paper which is actually combined between Dr. Ravindra Mehta and us. This was a two-center experience, our center and Dr. Ravindra Mehta's center. We wrote it. It's a defining expanded area in EBUS sampling, wherein we put our cases together. We had about 10 cases together, which was both intra and transpulmonary artery aspiration, which one was a PS sarcoma, one was a tumor embolus, others were transpulmonary artery. And we found out that adequacy was seen in 10 by 10, definitive diagnosis in 9 by 10. There was no procedure-related complication. So we, named it as EBUS TIPNA, which is trans and intrapulmonary needle aspiration using endobronchial ultrasound. We found that it's a safe and successful procedure. The subsequent review, which showed a transvascular EUS thing and EBUS, and bulk of them were used by EUS, and you can see that transaortic was done predominantly in EBUS. This was a whopping 100 cases done in a surgical setup. And there was one important complication that I would like to bring to the notice. It's called an aortic pseudoaneurysm that happened, where the end of the procedure in the aorta, the wall became thin, and there was a pseudoaneurysm which has a potential life-threatening complication. So that is something that you'll also need to know. And so transvascular TBNA was used only if pathological information on the target would change the clinical plan and no other targets were available. This is the most important thing. And bulk of the EBUS was done transpulmonary artery. Bulk of transaortic was done by EUS only out of this 100 cases. In this, this was in a journal of CTVS, and in 2019. So I'll summarize both the components of this talk by just 2 points. EBUS TBNA may have indications in high-risk situations. I say strongly may have and not will have. So you are very well justified in not doing this. It needs to be done only after good expertise is obtained. I'll be happy to answer questions probably at the end, because I'll over to Vishwesh again for the panel discussion. Thank you.
Thank you, Dr. Pattabhiraman sir, for giving excellent insights on two most advanced forms of the techniques in EBUS, which we generally do in a dire situation. And I think we will be having a lot of questions already. The questions are pouring in the chat box, but we'll take it at the end of the panel discussion. So following this excellent talk by Dr. Pattabhiraman sir, we have a excellent set of panelists for this panel discussion on USB, FNA, as well as transvascular needle aspiration. So we have Dr. Veerotam Tomar. Sir is a very senior figure in the field of our pulmonary medicine and interventional pulmonology. And he's the director at Dr. Shivraj Memorial Chest and Maternity Center in Meerut in UP. And he is a pioneer in the EBUS in North India. And he has, to his credit, a lot of awards, including the Savitra Kannan Memorial Best Doctor Award and Excellence in Healthcare Award and Inspiring Pulmonologist of India Award in 2022. He has been the past president in the Indian Society of Critical Care Medicine in Meerut branch, past president in IMA in Meerut branch, past president in NMO Meerut, and he is also a faculty in most of the national and the international conferences, and he is a workshop director in various conferences for EBUS, thoracoscopy, and airway management. So we have the second panelist, dear friend, Dr. Kaushik Mutraj from Chennai. He has done his MD in pulmonary medicine and has done his fellowship in lung transplantation from Vienna. He is currently the professor and the senior consultant at Sri Ramachandra Medical College, and he has been awarded the NCCP Young Scientist Award in 2013. And he has been a very close friend of mine for quite some years and has been doing a lot of things in the academic field as well. So with this, we have our third panelist, Dr. Rakesh Kodara. Again, he's a very good friend, and he's hails from Jaipur. He has done his MD and MD in pulmonary medicine from Bikaner, and he has done his IDCCM and FND and EDRM. And he has been trained in interventional pulmonology at Apollo Bengaluru and has been an observer in the interventional pulmonology at Cleveland Clinic in Ohio. And he has special interest in interventional pulmonology and does a lot of advanced interventional pulmonology in the state of Rajasthan. So we have our final panelist, a dear friend from the western part of the country, Dr. Jeenam Shah. He is a consultant chest physician and interventional pulmonologist at Sci-Fi Jaslok and Bridge Candy Hospital in Mumbai. And he has got his fellowship in interventional pulmonology from New Delhi as well as in Guangzhou in China. And he has got a diploma in allergy and asthma from CMC Vellore. He is officially certified as an interventional pulmonologist by IAB, and he's been a teaching faculty in the bronchoscopy in CIMAST, and he has published various national and international papers. And his field of interest as well includes interventional pulmonology. So
and I would like
think
to,
we have.
we'd like to introduce Vishwesh. Sorry, it has to be a thing. And I mean, of course, Vishwesh needs no introduction, but still, as he said, I mean, he's a young Turk. He's from the most happening place in interventional pulmonology, which is Hyderabad. I've known him for a long time, and Vishwesh is a very dear friend. He's done his MD, DNB in Patel Chest Institute, DM in Pulmonary Critical Care, and he was a gold medalist in that in Safdarjung Hospital in New Delhi. He's had multiple fellowships to start with from Malaysia, both in interventional pulmonology and sleep medicine. He had his European diploma in adult respiratory medicine. I'm a prolific publisher, around 30 review articles and original articles, oral presentations and various things. And now he's an invited faculty for various national and international pulmonology conferences. He's a reviewer in respiratory medicine. He's an executive member in guideline formulation of nebulization practice. But his field of interest, I mean, he's a co-director of International Interventional Pulmonology Meet, and multiple courses that he's conducted in his hospital, Yashoda, is a testimony to that. And his field of interest is interstitial lung, interventional pulmonology, ILD, and thoracic oncology. I'm quite happy to introduce Vishwesh. Over to you, Vishwesh, to take this panel discussion forward.
Thank you, Dr. Pattabhiraman sir. And so now we'll move on to the panel discussion. So my first question is to Dr. Virutham Tomar. So which lymph nodes are easily accessible by EBUS TBNA? And if I want to ask you, like, which are the ones you found it difficult to reach with your EBUS scopes? This is something very important for a person who starts doing an EBUS to understand his limitations as well.
Thank you, Dr. Shwet, and thank you, Dr. Patabi, for presenting very good presentation regarding EBUS. So, as we all know, the EBUS we can do the most of the paratracheal lymph nodes, or the lymph nodes around the airway, that are starting from 2R, 2L, 4R, 4L, station 7, station 10, 11, and even 12 if lower sides. But these can be very easily accessible. But the few are like, especially the para-aortic lymph nodes, like station 5, station 6 lymph nodes, or paraesophageal, which are station 8, or the pulmonary ligamental lymph nodes like station 9 are difficult to FNA with the EBUS scopes. So these are the few, or even you can sometimes 3P, that we call the retrotracheal, where we use EUS-B especially, and the lymph nodes beyond that, it's not possible to get the EBUS scopes.
Yeah, so this is very important because when you start doing an EBUS, most of the time you end up doing the station 7 and 4R, which are easily accessible in most of the cases. And I think when you face with the other lymph node stations, you need to have a proper planning before you reach it, because sometimes you may find it little technically challenging. So now we had a few lymph nodes which cannot be accessed by EBUS TBNA, and you need an EUS-B FNA. So Dr. Kaushik Mutraj, like, what is EUS-B FNA and how is it actually different from your EBUS TBNA in terms of technicalities and the node stations which you access?
Hi, Vishwesh. Yeah, so I'm audible.
Yeah, you are audible. Yeah.
Yeah, thank you. So, so the main difference between conventional EBUS TBNA and EUS BTBNA is basically here the scope, the EBUS scope, which we actually use for sampling the stations, is generally focused on stations like 4R and 10, 11, and 12, and station 7. But if you want to access the station 5 and 6 and some abdominal metastasis like adrenal or liver, then you usually plan for a US BTBNA. And the technicality wise, it has a very long learning curve. Other than that, the anatomical landmarks for the EUS BTBNA is a little complex. As a pulmonologist, I think your learning curve is very important when you're planning to do EUS BTBNA.
Yeah. Those are very exciting points. And for the viewers here, actually, to be very honest, USB FNA will be more comfortable for your patient to go through because they don't have cough and breathlessness. So any patient whom you feel like you have to do it under conscious sedation, they are excessively coughing or they are breathless or having hypoxemia, then USB FNA is a good alternative even for your subcarinal nodes apart from your station 5 and 6. And another few things which can help you is like here you don't have good anatomical landmarks and it is almost like a blind path which you take. You just have to go approximate against the wall. And another thing which you may feel different from a EBUS TBNA is that you don't feel the resistance of the cartilage. So many a times it just slides through, the needle slides through the esophageal membrane and then muscles, and then you can take a biopsy. And as Dr. Mutraj had said clearly, like your abdominal, like especially if you have an adrenal mets or a left lobe of the liver metastasis, then sometimes it can help you in staging as well. For example, you have a single isolated mets, then probably after you finish your EBUS TBNA, you go for a USB FNA, but never do your USB FNA before doing your EBUS TBNA, because once the scope is contaminated in the esophagus, you don't want to put it inside your airways. So with this, we move to Dr. Rakesh. So what are the anesthetic considerations or the oxygen delivery requirements you take care while doing an USB FNA? Or to put it in a nutshell, like let's say I want to do a USB FNA, like how do you oxygenate this patient, or do you go for any sort of a specific anesthesia requirements, or is it like much simpler than your EBUS TBNA?
Yeah, good evening, everybody. So that as in the talk, it has been explained that one of the major indication and one of the advantage of the USB FNA is that less requirement of your sedation. Basically, that a patient who is having the contraindication in terms of the respiratory failure or high oxygen requirement, or we cannot give the sedations that as sir has shown the patient where the compromised airway with the too much of extensive compression. So the patient, when we need to give the less sedation, so then we can definitely prefer, and the notes we need to go for access that we can either go for the EBUS TBNA and also USB FNA. Then we can choose the USB FNA with the less sedation. And sedation that generally we give the midazolam, fentanyl and all that we can use. And with the very, very less sedation and without the use of the general anesthesia, we can use the USB FNA. And second thing, the oxygen requirement, obviously it's a less oxygen requirement that you can give it by the nasal prongs and by the regular mean when you do the bronchoscopy. So this is one of the as is so it is more of advantageous if we are performing the USB FNA in comparison to the EBUS.
Yeah. So now we'll move to Dr. Jinam Shah. So in your practice, what would be the ideal indications you want to do an USB FNA? And when are the times where you really want to avoid a USB FNA? So basically, we are speaking about the indications and contraindications of USB FNA.
So, good evening, everyone. So, Dr. Pattabi Raman has already described what all stations can be accessed by EBUS. So, those are the stations which are not approachable by EBUS. That is the station 5, 6, 8, and 9, and subdiaphragmatic nodes, or station 8, 9, or you're talking about adrenal, liver, or any kind of other intra-abdominal lesions. That is the time that you always think about doing something more. That is USB FNA. But in my practice, generally, what happens is whenever we have a technical difficulty doing an EBUS, so generally when we do an EBUS, the patient is coughing too much, the patient is desaturating, you're not getting a good access to the lymph nodes, that is the time that you generally think about going a plan B. That is especially when you have a 7 lymph node or a 4L lymph node, that you can go inside and do an USB FNA. Many times we see that, the trachea is narrowed, some rare cases of tracheal stenosis or Malaysia, when the patient is, actually not a good idea to go to the tracheal route. That time you can think about EBUS, a USB FNA. There are lung masses sometimes which are near the esophagus. That is an ideal indication. Rather than going for a CT-guided central tumor lesion biopsy, you can directly go in for an USB FNA. The complete staging of the mediastinum, that is a medical mediastinoscopy, that is EUSB and EUS, EBUS together. That is one more indication. Intubated patient, as sir described, intubated patient, generally it's very difficult to go to the tracheal route. Then you can think about esophageal route. Very important indication that is done very frequently now is the children. Generally, children who are less than 6 years old, the trachea is very, very small. It's very difficult to pass the EBUS scope through the trachea. And at the same time, the EUS scope is pretty big, so you can't really go through that EUS scope. So that is where the USB FNA would be really helpful. Contraindication is as usual as a routine EBUS. Patient is unstable, hypoxic, bleeding, diathesis, not stop the anticoagulation. That time you can avoid doing. But one very pertinent contraindication I would say is any kind of esophageal stricture or any kind of esophageal masses. It's a blind procedure. You just don't want to go inside and just rupture any tumor there, or don't want to create any unnecessary bleeding. So in that time, you would definitely avoid. And any untrained physician, not really comfortable doing the procedure, should avoid this procedure.
Yeah, excellently put, Dr. Jinam. Now, over to you, Dr. Pattabhiraman sir. So in practice, like let's say that I want to start doing USB FNA from tomorrow. How stepwise I should go? Like what are the precautions I should take? How am I going to do it? And what are the challenges that I will anticipate while doing the procedure?
Well, I think we briefly discussed about all that, but I want to emphasize on a few points here. Do be comfortable with the tubes and accessories before you get onto this USB FNA. First thing, I understand that you don't need to do this, and if you have to do it, then you'll have to be quite conversant with the EBUS tube, EBUS needles, and you should know how it works. So you'll have to be quote unquote specialist. We would have had at least 100 or 200 EBUS under your belt before you would think about this procedure, because you are getting into a territory which is not technically yours, but it's a shared territory. And if things go wrong there, then unless you're a confident EBUS person, you will have a problem handling this. And second thing is, what we've done is we actually slipped the regular bronchoscopies into the esophagus on and off. That gives you an additional familiarity with the tube. We could actually use this bronchoscope to quickly shove it into the esophagus in a patient who is minimally sedated, and you can also have a look at how the esophagus looks, how the G junction looks, and so on, so that you get an idea about handling that thing. Most important thing is that there is a lack of endoscopic vision there. The esophagus is a floppy tube; it falls on your thing, and you don't really see anything. So anatomical landmark in the endoscopy is nothing. So it's a sonography, a part of your tube that's going to help you. So a few things. So first thing is you'll have to be conversant with the tube and the thing. And when you embark on a thing, Vishwesh has already told you, do it only after you finish with your EBUS and you want to do more. So because there is no chance that you do it and then come back to the broncho. So that's a very important thing to know. And the most important thing is the sterility. The potential to have an infection is something that you'll have to be having it in the back of your mind. Procedure per se, we'll have to do what is called as a pre-measurement. See, in the EBUS, in the trachea, it's a solid organ, and you can actually see the sheath coming out and all that. All that can be done inside the airway. Here in the esophagus, you might not be able to see endoscopically the sheath coming out. So if you're planning to do that when the scope is already in the esophagus, you might not be able to see the sheath coming out properly. We keep the sheath just jutting outside. If you keep the sheath a lot more, you might lose in terms of fineness and accuracy. If the sheath is very small, it's inside the thing, you might injure the scope. So what we have to do is you will have to pre-measure this. How do you do that? Before the scope goes into the patient, the technician will actually push this needle in, the EBUS needle in, and then you push the sheath out, and you make sure that the sheath is out, and then fix the needle. And so that needle will be fixed at that length. So the next time the needle goes in, it goes right away and the sheath comes out as it is fixed. So that is an important thing that you'll have to do, because you might not be able to do it with a lot of finesse when the tube is already into the esophagus. So that is one important thing that you'll need to know. Second thing is, have your anesthetist who is trained in thing, or you have your GI colleagues if you're friends with them, to identify things, because it's the same mediastinum, you're looking at it at a different angle. You're looking at it from the posteriorly, so you'll have to reorient your CT. Keep looking at the CT. You use the CT to look at the relation between the EBUS scope and the node. And now you'll have to look at the CT with a different mindset. Look at it from the esophagus point, and you can see that angles that are quite different. And so after that, you identify these structures, identify liver, identify diaphragm, identify left atrium, identify pulmonary artery, and then you'll have to automatically identify what else is there in this between 25 and 30 centimeters. Those are the lymph nodes. One is the subcarinal, one is the 4L. These are the things that you'll need to know. So you'll have to unclutter yourself, look only for these two nodes and sample only these two nodes. So identifying the nodes part of it is not going to be a challenge, because only there are so much. And the problem with the technicality of the punctures, that has already been alluded to. One is, it's easier to puncture the esophagus, but might be slightly more difficult to get it across the node. And again, the needle will keep moving independent of the node. That is something that you'll have to get used to, because it's a small node. You might be worried about needle not passing beyond the capsule, which doesn't happen, but it's a concern. It might go out of your focus and so on. So these are the technical issues, and always look for an infection. We might have to consider using antibiotics quite liberally. And if the patient is coughing, see, the complications of USB FNA are seldom talked about. It's not available in the literature as much, but if you talk to the specialists who keep doing it, there will be some, wink, wink, nudge, nudge cases where there has been a tear in the esophagus, the patient has severe cough, because esophagus is not a very strong structure. So be mindful of the fact that these are not very easy procedure. I wouldn't say not easy procedure, but not very safe procedures, if you like. I mean, when you compare it with the EBUS TBNA. So have that kind of a conscientious thing, do only when it is required. But it's a very easy procedure to, do it. I think the panelists can actually, add on to it.
So excellently good, Dr. Pattabhiraman sir, because it becomes a very important thing, especially when you're dealing in big hospitals where there's a lot of medico-legal litigations as well. So I think when you start off, it's always worthwhile to have a gastroenterologist at your backup to just understand how things are, so that you get a pretty good experience in doing it. So to Dr. Virotham Thomas sir, when you do an USB FNA, do you have any specific choice of needle or accessories which you'd like to choose apart from the conventional TBNA that we do with the EBUS scope?
Dr. Shwet, I have done most of the time I'm using 21 gauge. I've used all the needles, 22, even Procore needle I have used, but definitely I am now most of the time using 21. So there is no such difference between the needles. You can do any needles, but especially if you want to for fine, like you're having the needles lesion around the vessels, like if you are trans-aortic or trans-pulmonary, then definitely you can choose for fine needles like 25. Otherwise, my choice is 21. That is sufficient. That can give the both EBUS and USB. So there is no much difference between the needles, as per se.
I think I would like to ask this question to any of the panelists here. There have been few case reports of even EUSB cryo-nodal biopsies. I think we have also tried, but in my experience, it was like quite difficult to pass the cryo probe, because the membrane gets actually covered once the needle tract is formed. So anybody has any experience on, because there are some literature coming up saying that you can pass your 1.1 millimeter cryo probe as well through the esophageal route, but at a personal level, I got the material also, but I found it like little more challenging than the USB transnodal cryobiopsy. So anybody in the panelist has any experience to add on to, because it's something which may come up in the future as well.
I have not used.
I think Dr. Pattab, yeah.
No, I feel one more problem would be the endosonology vision.
But everyone, sir, I think you're on mute. I think, Dr. J.
Yeah. So yeah, thank you. I, I'm aware this is going to come up, and there already been an attempt by Felix in the group which did that, and I'm aware of friends doing it. Again, when EBUS, when you shove in a needle, there are a lot of problems. Imagine you're going to put in a whole, cryo. There are infection issues, and there are other issues like tear in the esophagus. Now, we've not really aced the safety data, so I wouldn't want the younger people to start it. For established people like Vishwesh, when you've or others sitting in the panel, it's okay. But again, we can't really advocate this at this particular point as a valid option because there are not enough numbers out there. There is not even a safety data among the high volume centers. Also, there is definitely a very a lot more of a problem to be expected because we have a very clear ways of showing a stiff cryo probe across the airway. That's easy. You can even you can make a puncture using electrocautery knife. You can make a big puncture. We can also finish it off with a APC, and there is not an issue at all. We can use a 19 gauge needle, but the techniques that has been described was just pushing the hole. I've heard people pushing a hole, not the needle, but the sheath of the 19 gauge inside to make a hole. We are creating hole in the esophagus. Creating a hole in the bronchus was initially thought about, to be a significant problem, but subsequently found that it's not as bad as we think. But esophagus is a different ballgame. So I have my own reservations about it, and I'll be extremely, extremely careful. Read a lot of literature and have experience from others, and then before I embark on this. And I would also think that why is there how are you unless it is going to be a paraesophageal node is the only node, and it is the only lesion which is carrying a thing, and where cytology was not enough, you'll have to get a lot more of tissue because there is a thing, and the whole life of the patient depends on getting that particular
Tire, and the third thing is like it is a domain which you are not an expert at. So I think it requires a lot of more literature and experience sharing before we start doing it. And
Yeah, Vishwesh,
yeah.
so one more thing, because then I think you said that you have done that. It could be a kind of possible thing because when we are pressing the cryo, the probe, and that we are keep on freezing when we are coming out because that's a muscular wall. That the chances of the tissue that get adhesed and then at multiple levels, because in airway then it's a we are just
Yeah, true.
that is one aspect possible.
That's what there's a high risk of there is a possibility of a high risk of a trauma. See, basically, I also don't have much of experience to comment on it, but it was just for the sake of discussion. And at this point, the disclaimer is like it is not something that has to be routinely tried or should not be tried as a novice. It is just something which is coming up in the literature, and we need more evidence before we actually even think about doing it at this point of time. And now we move on to the next question to Dr. Kaushik Mutraj. What are the challenges that you face during EUSB FNA? Like, are there any challenges? I think we addressed, but anything else you wanted to add on while?
Yeah.
Yeah.
So I think we heard it from the master, Dr. Patabi itself. Like he explained completely about what are the challenges. But for a beginner, I think starting with the anatomical landmarks, which you have to know before doing the procedure, is going to be a challenge. And moreover, identifying a landmark itself inside the esophagus is going to be because of a lot of fluids, and there could be a lot of other materials in the esophagus that could cause the low visibility. Third, probably is anchoring and positioning the scope, and accessing the target lesion could also be a challenge. And I think the most important part is the learning curve which you will take to master this technique. So I think these are the basic challenges.
Yeah. Thank you, Dr. Kaushik. And again to Dr. Rakesh. So we touched upon it briefly, like what are the non-lymph node targets that can be accessed by a USB FNA? Like anything
Right.
more you
Yeah,
you
so
feel, yeah.
definitely, because when we look at our the CT scan, and sometimes some lesions are not accessible through our endobronchial route. And one of the very common that a lot of literature with the cystic lesions are there, the medicinal cyst or the cyst are they are paraesophageal that can be
Going through this route actually really helps. And to Dr. Geenam, like any
easy.
further tips and the tricks you want to give it to the younger people who are starting with the USB FNA to increase their yield?
I think that USB FNA and EBUS, the tips of doing the procedure is the same. I mean, that doesn't really change anything. Couple of things that sir mentioned that first was, the puncturing is going to be a little tricky because the node also sometimes moves away. I mean, in the trachea, the node is generally stuck. So once you're through the trachea, the node is easily punctured. But in that case, in an esophagus, the node can move. So you have to be really vigilant. You have to see the endoscopic vision. That should be perfect. Second thing is all the routine things that you take 15-20 passes, and if required, you need to take in saline when you are suspecting any kind of benign disorders. And I mean, suction, if at all there is some pus-like material, or if you're not getting enough samples. Fanning technique, that's a basic thing that, multiple areas of the lymph node should be targeted. And always make sure that you're targeting capsule to capsule, you're traversing the entire path of the lymph node and taking samples from the.
You change the direction of your scope and you pass the needle so that you target multiple areas of the lymph nodes rather than focusing on one area alone to increase your yield. So again to Pattabhiraman sir, like what is your experience on using the EUS scope by pulmonologists? Like any experience? Like this is something I feel like it's like an overdue, but have you felt the need because that's going to give you a broader channel and basically I feel like it's like more of a gastro domain. So any takes on that, sir? I think we are not able to hear you, sir. Sir, I think you're on mute.
So I think Virotham has a better thing because he was working with Malay and he has access to this. And immediate thing that comes to my mind is that I wouldn't really want to use that scope, of course. And there are two different things that are there. There is one is the elevator which can actually push things up so that it steadies the scope a little bit. And also for gas insufflation, air insufflation, it's easier through the bigger scope. So these are the two things. I wish we had an EBUS scope which has a longer length. That would be a thing. And with a little bit of an elevator, if they can wing it, I think it will be easier for us to use it rather than having that bulky scope. I don't want to look at that scope. It's a huge tube, and I don't want any of my patient to swallow that scope. So I would really be, worried about using that kind of a scope here. And only thing is if only thing I felt about the EBUS scope while doing an USB FNA is the length is a little small. I would like to have a longer EBUS so that I could go for the thing, get down, follow the descending aorta and then get into the celiac axis, find out the left adrenal will be a lot more easy than this. So would be looking forward to a lengthier, maybe a little bulkier, but I mean, if there is a little, bit of an elevator kind of a thing, which that will settle most of what I would want to do from my patients for my things. I don't want that big tube inside anywhere near. Virotham, I would want to have Virotham's input here.
I agree with you, Dr. Pattavi. I started with Dr. Malay, and I started even EBUS with USB only, long back, 12 years back, almost.
I know that, and that's why I wanted you to.
So it's quite bulky, but for beginners, if you want to do the learn proper anatomy of because having wide angle, and if you want to proper anatomy of the mediastinum, then you can take help of your gastroenterologist to start with, to see all these like chambers of the heart from starting from not only left atrium, even aortic cusps and all these things, pulmonary artery, left, and all these things. Important thing is already mentioned that is the lever that has always fixed this lymph node, this scope very easily, and you can do the puncture very easily. Another thing is important thing is that if you go beyond this lymph esophagus and in the below the diaphragm, you can do very well these all FNACs of the liver malignancies, metastasis, or adrenal FNAC very easily. But definitely requires a good muscles, biceps to hold this bulky. But it's for beginners, you have to take this help of the gastroenterologist to learn this especially the EUS mediastinal anatomy. So
Yeah.
later on, I started. It looks like very easy when I put this EBUS scope in the esophagus, but initially it was the same way as you told. It's not.
So, Dr. Veeratham, don't you think that kind of R scope is two directional and there are four directional, so bit of kind of
Yeah,
tricky
that is
to
the
handle?
beauty of that EUS scope. That even you can do the good fanning with those lymph nodes. Even you can push some structures if there's large masses, or if you are the vessels are coming in between, so you can push by this large bulky scope to deviate this scope and get lymph nodes in the picture in the central. So that is not possible with this flexible, this our small EBUS scope. So, but definitely there's no necessity of buying this EUS scope for pulmonologist, but definitely if you are failed, you can take a help of your gastro colleague, or you can buy, or you should know how to do this EUS. And the same technique, except two more channels from up and down and the sideways, and there's a lever to fix the scope.
And with this, Dr. Veeratham sir, like, what is your experience on using this technique, USB FNA, in children? Because that is something where this
Only
can
way,
really
the
find its
only
utility.
way, definitely, as Dr. Ravi has mentioned, a 20-month-old child, he has put this. So it's in children where you're having very small caliber of trachea. Is the only way to get the mediastinal lymph nodes or masses to get the FNC. And it's quite easy. I think it's the most easiest procedure, I can say, easiest than the EBUS. So now the smaller 190 scope is you can put in the children, but it's better to get through the esophagus in the children. The only way I can say this is the best way to get a medicinal FNA.
Yeah, true. And Dr. Kaushik, do you feel like we are complete with EBUS TBNA and USB FNA? Will we be able to access all the mediastinal nodes for staging, or do you still feel like there are certain nodes which really become inaccessible even though you combine EBUS TBNA and USB FNA?
I think somebody who has a good experience with both EBUS TBNA and EUS BTBNA, I think most of the nodes are accessible. That's my take on it. But I think experience and
Yeah, I think the ioto-pulmonary window is something which you may find difficult even when you
yeah,
have an access of both. Yeah,
yeah,
because that
but
is again, that is, yeah.
yeah, sorry, you go on.
No, kindly go ahead, Dr. Kaushik.
Yeah, I think there was a technique which was mentioned by Liberman from Quebec, Canada, like how to access the aorta pulmonary window using the esophagus as a pathway by passing the needle next to the subclavian vessels and using the long approach. There is a technique.
As if it is the only thing that is going to change your management, then yes, that is a
Yeah,
risk worth
but
taking.
but, yeah, sorry, but I think that's not actually a transvascular. I think it's more a paravascular approach.
No,
So
I'm
yeah.
saying about what we will be doing, not about the
Okay,
Liberman study.
okay, yeah. Sorry.
Yeah. And to Rajesh, like Dr. Rajesh, so right now we are speaking about the transvascular needle. How safe is this procedure? And when do you really feel that actually we should be avoiding it? Even though, let's say that is the only node which is going to make a difference in your management. You have to do it. You have the skill to do it. But when will you avoid it?
So very important question, as sir repeatedly mentioned, even after the literature he has shown that kind of it is when we have to think of that whether do I need it or not. If you have only the option that only the node that we have to access through the transmuscular, and then other options are not either the failed or not possible, and that is the only pathological node that can change or alter your management, then definitely you can go for that. But avoiding, obviously, then the common in the complications are that the contraindications that definitely we should avoid of, that are the coagulopathy or the bleeding or the patient's on anticoagulation. But with the safety considerations and the keeping in mind that we can do this thing and it can be doable, because sometimes we have seen that some even the radiologists or IR people, they deliberately puncture the are the vessels, and sometimes even we generally we take sample from the 11R and we can get a puncture to a pulmonary artery, that we know that it can be punctured and not to be a complication. Third one is the important that the too much of, like, suppose we are sampling on a gestation 5 and if in a aorta the too much of your atherosclerotic plaques are there and all. These are the things where that if that better you avoid, because then that this plug can rupture and then patient can lead to the your stroke and severe. So that I think then checklist is very important, that what you need and what you need to do, and after that the careful considerations, better you see your anatomy, and then you can do it, but not too much of passes, because one or two are the maximum passes we can do. And so these are the things that where we can do, and when we need to avoid it.
Yeah, that's very, very good points. Apart from your bleeding diathesis and conditions like uremia and other things, especially when you have an elderly patient with extensive coronary calcifications or
Absolutely.
vascular calcifications, which you can pick up from CT scan, then you should be really cautious because you may end up causing a trauma to the vessel. And as you rightly said, plugs. So when you have lots of plugs, there is a possibility of embolization of these plugs and causing a stroke as well. So, Dr. Geenam, can you describe in brief about how you plan it and how you do the transvascular needle access? Like, what are the steps in detail? Anyway, it has been discussed extensively by Dr. Pattabhiraman sir, but still, for the interest of the audience, how do you really plan it? What are the precautions you take? And stepwise, how do you do it?
So planning has already been discussed. I feel that, it should be the last possible route to biopsy. You have exhausted all other options, and this is the only option which is possible. That time you think about doing this procedure. The procedure is more or less same as an EBUS conventional. I mean, you do as an EBUS TBNA. But the most important thing is you should, if you have multiple nodes, this should be the last attempt. I mean, you should have finished all the nodes, because there can be some amount of bleeding after this procedure. So you have to always do it as the last. A needle, you can, try to pick the smallest possible bore. If 25 is available, then 25, otherwise 22 or 21 you can do. First is to locate the lesion. The second important thing is to target the lesion in a way where the particular vessel is the least in diameter, because you only have a 4 centimeter throw of your EBUS needle. So if you are, having a big vessel which is around 3 centimeters, and you are trying to target that through the 3 centimeters, you'll hardly have any amount of needle which is left for that particular procedure. So generally, when you rotate your scope, you'll find one area where the size of the lymph node, the diameter of the vessel is little smaller. So you target that area from that particular angle. Puncture should be slow, and once you have punctured, go through and through the vessel into the node. And then once you are doing the jabs, make sure that you're not passing the node again and into the vessel. You need to be inside the node only. Take 10 to 15 passes, how much ever is possible. And then when you come out, the first thing that you do is the rose procedure. Rose, because you don't want to do unnecessarily more passes through that particular vessel. So try to do the rose. If you're getting enough material, then you are done. You don't need to repeat the procedure. And immediately once you're done with the procedure, please check for the bleeding. Generally when you're doing the procedure, you do not realize, because the scope is approximated. Then check for the bleeding. If it's bleeding torrentially, or if it's significant bleeding, do your cold salines and Atiline, and everything should be ready. And if it is bleeding significantly, you avoid doing further procedures after that. I mean, that is
Yeah.
the less things.
Yeah, perfectly put, Dr. Jinam and Dr. Pattabhiraman sir. Like, I think you are the person who has got a maximum experience in this transvascular. So, what complications did you really face, and how was your preparation before taking up the first case? So, what did you anticipate, and what really happened during the course of the procedure?
The first couple of cases was fear of unknown. We didn't know what to expect. We expected bleeding. It didn't happen, of course. And the most important thing is we started with the aorta. Aorta is a little difficult. Aorta is difficult because one, it's a 3 centimeter thing, and two is because it's. I mean, the scanning range is a little off, and so you start in one end and you don't see the needle at the other end. So you have to make certain assumptions also. Third thing is, as already has been alluded to, always there is always a plaque and the cholesterol emboli, stroke, and all that stuff. So cholesterol, I mean, aorta, transaortic is not a very pleasant thing. Transpulmonary is a lot easier. Look at it. We've inadvertently poked when our blind TBNA or conventional TBNA is days. I think that is not a vessel that I have not poked while we are doing a TBNA conventionally. So, poking one side unintentionally might not be less harmful than poking it intentionally. Uh, these are big vessels which have a thick coat, and so they usually think. And as someone has suggested, the radiologist did it. Yeah, I think in the abdomen area where they go across, they put cannulas and so on. So I think. And that is not the worry. But when you look at it, when you're intentionally doing it in a procedure, which is again quote unquote nascent, you'll have to look at the complications very carefully. In all these, there has been minor complications, and minor is a little bit of a trickle of blood, and that's all. But one dangerous complication, that thing was the pseudoaneurysm. The pseudoaneurysm is not something that you can really sit and wait. It has to be intervened. That paper did not show how it was thing, and they said that it conservatively managed, but a conservative management of pseudoaneurysm is an endovascular graft. So I think those are the things that should be a thing. At this point, we do not have a thorough safety records for all this. And as has been emphasized multiple times, do all the due diligence. You use the 4R, 4L, even if the nodes are smaller, in the closer to the airway group than the away from airway group or the closer to the vascular group. You do all the due diligence and do poke everything, have a rose, make sure that you've tried everything. If not, go for a CT guided. It's easier. Go through the other side. When you want to reach a lesion which is station 6, go through CT guided. Going across the lung is not a bigger. You can't do anything more than going across the aorta. So if you have done that and if you have not found it, then it is quite easy to do this. And if you ask me what the complications are, I will say nothing, because all the cases that we've done, we've not had any complications. But the numbers are not very good to say that don't worry about this. So that is something that we can never say. So to the question, what are the preparations? Do you have a cardiothoracic surgeon as a standby? No, I don't think that's all going to be possible. You might have a problem like a pseudoaneurysm, which gives us time for it to act. So in which case, we might have to send him to the cardiothoracic surgeon at some particular point, or send him to an interventional radiologist at some particular point. But having them in a Bronx suite doesn't make any sense at all. So I think these are my thoughts on this. It's a jamboree of thoughts. It doesn't come. I think it's up to the young pulmonologist who is interested in EBUS thing to decide whether this comes in their thing, and if it comes, it better come at the well-trained level after all these USB FNAs, because these are relatively easier ones. Let this be the final frontier, as Pancha Bhai put it.
And I think, like, if you really have a very good cardiothoracic surgeon, they can even go through an anterior approach to sample these nodes too. So I think it's a trade-off between the risk and the benefit which you are going to take. And to Dr. Virotham sir, like, let's say that you ended up doing a transvascular and you are with a bleed. So let's take a hypothetical situation. What is going to be your reflex and how is going to be your heart rate?
Yeah, definitely. It's very, if you're definitely, if it's pseudoaneurysm, definitely you requires a thoracic surgeon CTVS opinion. And even sometimes if the bleeding, as Dr. Patavi said, the grafting, the endovascular grafting is maybe the option. Otherwise, another possibility you can, I think is the option, you can keep the blood pressure lower side. If there is a high chance of the patient is having hypertension, then I think, like in any bleeding during surgery or anything, so you can keep their blood pressure lower so that it can not bleed by very much. Otherwise, in EUS, with larger scope, you can even press these vessels if for some time if it works. Otherwise, for simple USB scopes, I think it do not work. Another precaution I should say we should take while doing TVA, like if patient is having invasion of vessels, if mass is invading the vessels, you can see by the ultrasonic images, if there's a fat prints are going on, you should avoid the FNA at that moment. If there's a walls of the vessels is very clear, not invaded, then you can try. So regarding this, how to stop, I think there's all these hypotheses I am putting here. I don't know how it works practically actually when you are in the OT.
Yeah, very true, sir. I think the dictum still holds good. Call for help. So that is the first thing you can do. And I think most important thing for all the youngsters out here is when you start off with intervention, you are excited that you don't communicate what you're actually going to do to your assistants and your anesthetist. So that's a very important thing, because if you are paralyzed, you need to have one person who thinks logically and helps you. So having a realistic discussion with them prior hand planning makes a lot of difference. And one another thing in most of the setting is communication to the attenders. So sometimes you are so enthusiastic that you want to do it, but you end up with a complication where there is no proper communication to the attender. Then it becomes a real nightmare situation for you. So to Dr. Karthik, do you have any personal experience on this intravascular, or for that matter, any of the panelists? Do you have, I know that Dr. Patabi Rahman has shared his experience, Dr. Jeenam Shah. Apart from that, anybody has got any personal experience, or you want to share anything related to this transvascular needle aspiration?
Hi, Vishal. I think to be honest, we have not done any 5L so far, but then we have done few of the transvascular in the lower pulmonary nodes through the, because there was the only node, but then there will be a vessel which we have to traverse through. But we have done that. But then personally, I don't have an experience with 5L.
Yeah, I think we had heard the experience of others. And to Dr. Rakesh, do you always keep a thoracic surgeon in the backup when you do these? That was a question which is already put forward by Dr. Pattabhiraman sir as well. Does it really make a difference? Because once or twice, like we had we were doing a procedure, we had an airway bleed, which eventually got controlled with a Fogarty balloon. I called my thoracic surgeon just to be in case if it becomes a complication. The first thing he said is, "What do I really do in this?" So, do you feel like having a thoracic surgeon next to you would really make a difference, or it is just like you want to put half of your blame onto the thoracic surgeon, saying that he was also a part of your procedure?
No, so that's kind of very rightly said, because then all the interventions that we can extend are the risk-taking capabilities, just because the surgeons are nearby. The same thing is with the GI people, because when they are doing that esophageal dilations, that always then if there is rupture and all, then immediately they transfer the patient to surgeon. Same thing with the ASD closure and all. If they are not, then the same thing is there. Then it's are more of the risk-taking capability that said that if we don't have any options that we can push, and then keep the surgeons in a loop that for the kind of a completion, but that at that time, whatever the complications mentioned with this technology or whatever the procedure we are doing, it is more of the bleeding that majority of time that's self-limiting, because in the same paper that sir has mentioned, in the 100 patients they have done that, in the out of that later on they have done the 3 or 4 patients surgical, and they saw the bleed there that was limited by itself only. So that at that acute time, that surgeon will not do or cannot do anything, the majority. But then definitely that because if the things are more, because we need to keep in a follow up, and one of the important consideration that we need to keep these patients for more follow up, so slightly more longer hour of the follow up. If any complications happen, rather than the usual conventional patient for EBUS, we need to keep in a observation. So this is the one thing that I need to mention. I think.
Very true. And I think we come to the last question to Dr. Pattabhiraman sir. I think he had already shown his experience, and what would be your last line to the youngsters, sir? Like, if you have to say one word, I think you have given a lot of guidance to them already. But anything you want to say in particular, like while taking up this procedure, before
Well,
we
I
take?
think, yeah, I think,
Yeah.
see, just learn all the right things first, and you can always. I mean, once you reach a point where you are comfortable with this, with all the scopes and techniques for the with the indications that it has been designed for, once you are very comfortable with that, I think that is when all these things kick in. Be responsible. It's a very good tube. It's a very costly tube. Don't misuse it and make holes, because it's very, very difficult to get loaners these days. So be very careful about what you're doing. Be very conscientious. Be a champion for the patient and not for the procedure. All these has been told by people who've done this in the past. So it's my obligation, my duty to say that all these have to be done with due diligence. Having said all this, never shy away from things. When you have a competence level, when you are faced with situation which demands innovation, but you be prepared, and so have that streak in you, which will also ensure that you innovate, because bulk of all the these things that come more by serendipitous or some inspired moments, and so that has become become a standard of care subsequently. So I think I keep thinking and keep innovating. but use it with a lot of diligence and be a champion of the patients rather than the procedure. I think that is the most important thing. That's Dr. Atul Mehta's line that I'm taking, which is be a champion of the patient and not the procedure. Use it more responsibility. But I think this is a wonderful, you know, EBUS is a very versatile tube, and you can do a lot of things with this. But for all that, I would always stick on and say that do your proper EBUS, finish about 500, 600 EBUS and be very, very, very thorough with the procedure before you embark on any of all these that have been discussed.
Yeah, I think we'll take a few of the audience questions. So we'll start with Dr. Veerotham, sir. How useful and practical is to use EBUS for mediastinal tumors? A quick take on these questions.
It's a must to get EBUS for the medicinal tumors. And as Dr. Patavi showed in his slide, one of the slides that says even in the lung parenchymal mass, you can do this FNAC quite easily. So for staging and everything and for confirmation of diagnosis, that is a must.
Yeah, and Dr. Jinam, how do you troubleshoot difficulties with bronchoscope navigation or ultrasound probe placement? I think this is something, maybe do you want to put a balloon when you're targeting the paratracheal or when you're targeting the intravascular?
Yeah, so balloon is always very necessary, as generally when you are in the EBUS, there's a lot of air. Without the balloon, the approximation cannot be that great. So always make sure that the balloon is already put in prior to the procedure being started. Inflate the balloon to an appropriate size so that you are getting a good approximation between the airway wall and the scope, and then the vision becomes a little better. You need to know the nuances of the ultrasound. I mean, there are a lot of parameters like resolution, frequency, gain, and all those things. You need to know understand that, because as a trainee when I was there initially I couldn't understand that. So once you get the hang of it, you will get better images of all those things, and it is easier to place your scope and then take biopsies from there.
Yeah, and again, what are the indications and contraindications of USB FNA? I think it has been dealt with. How do you select your patients for USB FNA? As Dr. Jinam has already said, any patient who is in distress or pediatric patients, or you have a narrow tube where you can't negotiate your EBUS scope. And this is to Dr. Mutraj. What is the role of imaging studies in planning USB FNA? Does it really help? Like, do you look into your CT scan? Anything in particular you want to look into your CT scans before you plan a USB FNA?
Yeah, I think first thing I would like to look at is there any accessible nodes for the conventional EBUS TPNA? So that is the first thing I would like to look at. Only if it is not there, and only if there are nodes which are not accessible through a conventional nodes, then probably I will plan my EBUS EUS BTBNA. So that's the very important aspect. Other than that, I don't think imaging as such might have a very big role, unless until you have a contrast imaging, which should actually tell you if there is any vascular structures which you have to traverse when you're doing a procedure. So that's my.
Yeah, true. And this is to Dr. Rakesh. How do you navigate the bronchoscope and ultrasound probe during the procedure? Like, I think you don't have any landmarks, right? Like, so how do you push? Like, you just push
For
it blindly, or
USB.
you make them swallow
So
and push
yeah,
some
so
air
one
to
thing is
make
that
it
kind of the
comfortable?
swallow is there. One second thing is that the problem with the this this kind of endoesophageal vision. Basically, either you can do the kind of air aliquot with the 50 cc syringe, that you can create a kind of a air and then slightly you can see, because we don't have a habit to go blindly. Second thing, then one of the paper mentioned about that you can start the oxygen by your working channel and then at least 2 6 to 7 liters, so that at least it can give you some space and you can see endoesophagally. That is the one thing, do easier rather than going a complete blind. So these are the method later on that it can click very easily, and because these things will help us about that if any kind of a stricture or ulceration or there, so we can avoid all these things. So
Yeah.
later on that with the mark, because here in the esophagus more of the mark is more important, that how much from the distance from your incisor, and these are the landmarks. So that's why then we start that while going first crossing the G junction, and then we check for the liver and diaphragm with the hepatic vein, and then we gradually come up. This is one of the process we follow it, and it's more of the initial that we need to do if we really want to practice that in a patient, that you can regularly do in a practice, because you just familiar with anatomy, and then as you rightly said, call your the gastroenterologist then for initial for the 5 or 10 cases, that to better understand the anatomy, if you really want to familiar, because then initially for the competency you need a good anatomical knowledge. So these are the 3 or 4 things that you can do, and once you are get familiar, then you can select the case, because initially then you just go through and then go familiar with the anatomy, and the later on whenever the any real case comes, then your competency and your adequacy or the yield will increase.
Sure. And I think this question would be ideal for Dr. Pattabhiraman sir. Like, what are the uncommon yet common indications of USB? Like, is there anything, something you want to say?
I mean, for us, the way we've been doing USB regularly, the uncommon indications have been patients on a mechanical ventilation. It's not been very common that we've been using for that, but that has been quite exciting as well because there is no other way of making a diagnosis in that particular patient. So that would be one indication for a USB. Second thing is a mass around thing. So we look at CT quite differently these days. And once we start having, you see the lesion which has the first thing we look at is how far away is it from the airway. We look at the bronchus sign to see whether it's a radial probe thing in a peripheral lesion. And now these days we also see whether there is especially in the sixth segment around areas around sixth segment, if there is a relation with the esophagus. So we can do a convex probe EBUS, TBNA, real time of a mass, and then you can make a diagnosis. So those are the things. So mechanical ventilation and the mass around the esophagus are the ones that are uncommon but quite exciting indications.
Yeah, and to Dr. Virotam sir, how do you tackle diagnosing lymphomas using USB? They have asked for EBUS, but I think it is for USB.
Pardon?
Any lymphomas, like how commonly are diagnosed lymphomas using an USB FNA? Because FNA little quite difficult to get a lymphoma diagnosis because of the lack of tissue. So I think that would be a challenge, right? Like, and
I've tried, like even 19 gauge needle, even Proco needles you can try. But I've tried that all these are having the same results. Even literature said this all having same results, even if you do the 21-20 gauge needle. So there's no special anything you can do with the regard apart from the EBUS or EUSB. But definitely before sending this cytology to the pathologist, that Patavi already said, you should mention that this is from esophageal route or this is from the tracheal route. Definitely from the tracheal route you are having the squamous epithelium, and while from the and if you are getting this, pathologists may get confused. So lymphoma, I think we can say regarding the cryo, I'm not aware, or it's quite risky, as already mentioned in the previous panel discussion. This is not, we should not try it.
I think we are
If I
having
may
some.
add,
Yeah, please, sir, please.
yeah. So if I may add, if there is a chance of this being a lymphoma, I would reschedule for a EBUS again and do a cryobiopsy through the EBUS route after. I mean, if the cytology is suggestive, high-grade lymphoma can have a suggestive thing on an EBUS, EUSB. You can never be sure. So you might have to reschedule it either as a EBUS transmediastinal biopsy or a mediastinoscopy if it is available, or a transthoracic thing. Subsequently, there should be a scheduling. As a last resort, if nothing else is possible, then only we can actually think about a cryo of from the esophagus. I see no other indication for that.
Yeah, and I think you have still VATs. Like, if nothing works, you can still approach your
That's
surgeon.
what I'm saying.
Yeah. So I think we are going to have a very exciting, innovative questions. So we'll start with Dr. Jeenam. How do robotic assisted bronchoscopy systems complement EBUS? Like, I think our audience are in next league. I think we should not stop the module with this most probably.
After EBUS, Transvascular and USB FNA, I think they are going for EBUS robotic guided something else.
So I
So,
think
I mean, I feel that, in the EBUS, any which ways you have the vision which is right there. I mean, you can see the node right under ultrasound vision. So I'm not sure how a robotic assisted EBUS would really help in this case, unless you're talking about radial probe and all those, peripheral lesions. But central lesions, you already have it under your vision. So, I mean, I don't think so there's going to be real help with a robotic system, I guess.
Yeah. So that's for the future. And so coming to the future again to Dr. Rakesh, role of artificial intelligence in EBUS image analysis, like quite interesting.
So I don't have any too much of an experience about that, but definitely, first of all, the pretest probability is one of the important things that can the planning for that, how we need to sample, and because one of the elastography is there, and so second thing is the so in our pathology also, then AI can help us to better these are some of the areas because it's quite new because so this I think and still I think more to come.
Yeah, and to Dr. Virotham sir, we know that in EUS elastography plays a key role, but somehow I think in EBUS, even though the technology came, it didn't make much of a difference until and unless you have repeated negative and you want to target one specific portion of a node with a strain. So what is your experience on elastography in EBUS, Dr. Virotham sir?
Yeah, I've tried definitely in US, like where gastroenterologists are using because they can press the technique of this straining is basically from the when you give the pressure on the lymph node, it checks the stiffness of the lymph node or the mass. But in USB, especially smaller scopes, doesn't have such doesn't create so much stiffness or give pulse to the masses. So, but definitely, if you're I've used several times this technique, but you can say you can only choose that this is areas having high chance of high probability of malignancy. Otherwise, you have to take FNAC from over the from core to core, and you can say it's not definite diagnosis. It doesn't give definite diagnosis. So, but just give a road map from where you can take a FNAC, where is
Yeah.
the benign structure, where the malignant on the basis of the
I
blue.
think the only utility is when you have repeated negative passes to target possibly to which part of the node you want to do it, then probably yes. And what is the role of EBUS in patients with recurrent or unexplained mediastinal lymphadenopathy? I think that is the answer. EBUS is the answer. So I don't think. How do you handle non-diag? Okay, this is something very, very important. Like I think we'll take it to Dr. Patabi sir. How do you handle non-diagnostic EBUS TBNA results? Yeah, that's
Very
something which is
poorly.
very practical.
Very
Pardon?
poorly. Very poorly, I said.
I think we'll be
If it
on
is
the
done
deck of
by
the
us, it will be very
pathologist.
poor. So no, I think if you look at across the papers, you'll see about 5 to 10% of them being non-diagnostic. This is something that if you do enough, you will get into this, and this is something that you always have to. So the first thing is we've now identified. We've now said in the consent process, we'll have to drop certain numbers. You'll have to say that this procedure you can give it a 95%, in which case there is a 5% chance that you might end of the procedure and not have an answer. This needs to be stated upfront and in the consent process documented upfront. These days, I think that's very useful. Previously, initially, when used to own this procedure, we used to fight with the pathologist saying that how can you not? I mean, I've done a rocket science in terms of having the needle inside the node, and I can see that the needle is inside the node. How can you say that the node is not inside the needle? We now realize that there are enough reasons why that can happen. There can be a sarcoid, can be a strong fibroblastic response. By way of being what it is, you can see you can never have a diagnostic thing in most of in some of at least some of the pathologies, and so yeah, you have to be very clear upfront about there is a possibility of about at least 5% chance that this doesn't give a proper diagnosis. Again, it is when the pretest probability when you diagnose, it depends on what you're doing this EBUS TBNA for. So if it is for a unexplained mediastinal lymphadenopathy, if you look at all the papers, it's between 80 to 85% is the yield, which means there is a significant amount of nodes that doesn't give an answer, in which case you will have to ROS will be very useful when there is a ROS negativity. Nagarjun has proven that when there is a ROS negativity, you can actually embark on the cryobiopsy and ensure that there is an additional increased percentage of making a thing. Even despite that, there can be some unexplained mediastinal lymphadenopathy. So ROS is a very useful idea in trying to go for a mediastinal biopsy, including a cryomediastinal biopsy. So that is in terms of an EBUS, with specific reference to EUS. I'm not answering it in reference to EUSB. This is generally about this. If you are doing it as a staging process, if you do a proper staging which includes EUSB, we have a very high specificity and a very, very high sensitivity also these days. We are looking at a 95 to 97% sensitivity. So if you do a proper staging, we'll usually not have we'll not have, what shall I say, a failure of the procedure. We can only say that whether the nodes are involved or not, and subsequently proven wrong in about at least 2 to 5% of the times by the time the surgeon goes in and he finds out a full node which is involved, which was negative in the EBUS. So staging is a different process. What is a more difficult problem is when you deal with sarcoidosis. Never stop only with the nodal sampling. You always go ahead with endobronchial biopsy or even a transbronchial biopsy. Because if you identify granulomas in 3 different areas or at least 2 different areas, one from the node and one from the airway or in the parenchyma, then we have a robustness in terms of a diagnosis. So even if you miss it out on a node, you can actually pick it up on the airway or a parenchyma.
Absolutely.
So if you're looking for sarcoid, which is a pre-test possibility, never stop with EBUS alone. So that if you stop with EBUS alone, you have a 20% chance of not making a diagnosis. But if you use a combination, you have a less than 10% chance of missing a diagnosis in sarcoid. If it's going to be tuberculosis, again, you triage it with the rows or you just send it for everyone. Use all the microbiological samples along with the pathological samples. So you maximize your yield. When it comes to lymphoma, when the pretest is a lymphoma, and if you're getting a negative on a rose, then again, this is the indication for a cryomedicinal biopsy. Never stop with just rose negativity. And so say that I don't have an answer. Just try and make sure that you make your maximum extent in terms of diagnosing a lymphoma. However, there is still about a 10 to 20% chance of not making a diagnosis in lymphoma setting. Always hand it over to a surgeon when there is a higher possibility of a lymphoma. The other more important thing is a post-chemotherapy restaging. That is a very important thing. Now we are getting more and more of these cases where a restaging is there because of the fact that the chemotherapy can cause a lot of fibrous changes in the lymph nodes. The chance of the micrometastasis being very patchy. Always use a fanning technique. Try and use biopsies also. Those are the cases where you use a lot more of these advanced tips and tricks to ensure that you maximize the yield. Despite that, there is again a 20 to 30% chance that you might be missing out on a micrometastasis happening in a post-chemo, restaging in things. So if you handle how do you handle a negative EBUS TBNA is very, very dependent on what you're doing that EBUS TBNA for. Whether you have done a due diligence and you've done all that is possible with your EBUS, and despite that, if it is negative, you'll have to accept your thing and then go further in either handing it over to the surgeon for a mediastinoscopy or in certain cases, definitely following it up closely with the repeat PET or a CT in 6 weeks to 8 weeks time.
Perfectly good. And to Dr. Virutam sir, what are the key factors that influence the diagnostic yield and complication rate in USB FNA? So any pointers to say that this is the case where I will get a perfect diagnosis or predict complications?
Regarding that, as Dr. Patavi said, if you are having the negative EBUS like previously, my usual practice is if you are probability of any disease like the sarcoidosis or this lymphoma, I usually do first EBUS and same patient after visualization, I'm not doing the rows, but if you are seeing that there's a acanthrotic material on the slides, the smear are good, you can you can say by experience you say that this is a positive, it's a visual impact. But I always do a repeat EUS on the same patients for the same lymph node from the posterior side, so that almost you can say I'm having more than 95% accuracy of the lymph node. While doing this EBUS, EUSB, the only complication you can find sometimes is already said, there's a tear, is a high probability patient is having coughing. So you may end up with a tears. So that is the only, I think, complication you can say while doing the EUSB. Otherwise, one more thing I want to add here that is not mentioned in this, we have not discussed. Even if you have fixed previously this sheath in the EBUS scope, before putting the scope into the esophagus, you always should check at the mark of the entry of the needle, where there's a blue or green dot is coming on the right corner upside of that window. If you do the sheath forward, you can see some dipping, any indentations you will see on that images that confirms that sheath is out of the scope. That is very important. Sometimes when you put the scope inside after fixing, it goes inside and it gives sometimes you either puncturing of their scope. So always check that sheath is out by seeing the indentation of at the corner of the right upper lobe where the needle comes, the blue dot or the green dot. You should see that indentation is sheath is out or not.
Yeah. So I think we still have lots of questions, but I think most of them were like sort of a repetition. So I would like to take 1 point from each one of you. Like we'll start with Dr. Virotham, sir. So your take for the audience on either of the topic, USB FNA or the transvascular.
I must say, I'm the strong propagator of USB. So don't afraid of getting. It's more easier than putting Riles tube. So even and start this USB and start visualizing all these medicinal structure through these USB, so that you get more alienated with the structures of the medicinum and the vessels. And the same way, when you learn this ultrasonic image in the USB, try to follow that same images into the trachea. That will be more easy to follow the different stations from like where the brachiocephalic vein is crossing. There's a 2R, the 4R, where the zygus. So my take is that you start with doing it. Don't afraid to get this USB. It's quite easy, more easier than the putting the Riles tube, and don't afraid that.
And Dr. Jinam, anything from your side?
Yeah. So indication of the procedure should not be the fact that you know how to do the procedure. I think you need to be 100% sure before embarking on all these transvascular, intravascular biopsies. You are 100% sure that you have tried all other modalities, CT-guided biopsy or EBUS TBNA, and you have exhausted all other options. Then only think about doing that. I mean, it is not reported too many complications in the literature, but each and every one of us, if you ask honestly, we have had bleeding and all those kind of complications that can happen, and it's not really a pleasant sight. So make sure that you have done the correct steps first prior to embarking on all this kind of complicated procedures.
Yeah, and Dr. Rakesh?
Yeah, so I will reiterate the fact from the Dr. Tomer also. The thing you should know that how to do it, and then you get familiar with the anatomy from the different point of view or different angle, because that's very important, because it increases your bandwidth when you are in trouble or when you are not able to access to some difficult areas. So you can do that part, and later on then you will be more kind of wise that when you need to do and when you don't need to do. And for second thing is the same with the transvascular also. So as sir rightly mentioned, that the puncturing will not cause too much of kind of the things. If the careful selection of patient, it can be done basically, because same thing then with the critical ill patients, we do puncture with the subclavian, and sometimes then we puncture the subclavian arteries also with the even significant large bore or needle and all. Then we don't see the too much of hemorrhage and all. So it can be done, but with the proper then kind of your checklist and risk assessment, and also that why you are doing it.
Yeah, and Dr. Kaushik, your take?
My take would be for EUS TBNA. I think while we are doing a conventional EBUS TBNA, I think we can use the same EBUS scope and visualize the esophagus to begin with for few procedures, rather than doing the procedure, doing the FNAC. Just go into the esophagus and get familiar with the anatomy, and then probably when there is a need to do a procedure, then it will be easy for you to go ahead and do the procedure.
Yeah, and Dr. Pratabiram, sir, your final words. A short one for the audience.
Yeah. So I think I mean, both the procedures are quite exciting. USB FNA is more practical and more informative. Transvascular is, I mean, something that you don't need to actually do in your rest of your life and be quite happy with the EBUS thing. But USB FNA is something that it's a lot more important, and so you can actually spend some time in learning about the anatomy and then doing a few cases actually, where with the initial thing with support from your GI colleagues or someone who's trained with this senior EBUS scope is. Transvascular, again, it's up to you. After you become very conversant, if you have certain lesions, then you can still try out, but follow due diligence. That has been told. Make sure again, try and avoid aorta use of pulmonary artery. Aorta is depending on the angle you go, it might be more than 3 centimeter, and the needles might be found short, and you might end up doing an ABG in a very convoluted way rather than trying to take a biopsy. So try to do, get a, I mean, due diligence is what I would like to all of you to use, and I think these are exciting indications, and I think once you're doing you're in the EBUS business, you might end up getting all sorts of things. So I think that's it.
So excellent points put forward by all the panelists. I think we have actually extended our time limit as well. So to just put it in a nutshell, anything you choose for the safety of the patient, safety of the scope, and safety for your practice as well. So you need to put all these things in mind and choose the right one. And it all looks exciting, but everything has its own set of a learning curve, and we learn as we do. Never shy away from doing, but make sure that you have all things planned up before you enter a domain which you are not aware about. I think we had a very I hope that this module was informative to all the participants here. And in the end, I would like to again thank all the panelists once again, and especially Dr. Pataviran sir for his excellent talk. And I'd also like to thank the IAB for curating this module series, which is very beneficial for most of the budding interventional pulmonologists across the country. And a special thanks to Dr. Mehul and Dr. Amita for spearheading this program, and to Mankind, and especially to Mr. Nitin for supporting this good academic initiative. And finally, the thanks to all the audience as well for keeping us busy with so much of questions, which essentially means that the webinar was listened to properly, which was for the benefit of all of you. So I again thank each and everyone who has been a part of this program, and have a good night. And hopefully you get your first case of transvascular needle tomorrow only.
Excellent.
See you.
Yeah, bye. Good night. Good night, everybody.
Good night, sir. Good night.
Bye. Bye, Patavi. Bye.
Good night. Bye.
Bye, sir. Bye.
Bye. Good night. Good night.
Good
Bye,
night.
Rakesh.
Good night, all of you.
Bye, Vishwesh.
Good night. Bye.
Bye, sir. Good night, sir.
Bye, coach.